Welcome to OET Answers.
Occupational English Test. OET Answers Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1. Questions 1 to 12. You hear a GP talking to a patient called Mrs. Rachel. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi, good morning. It's Mrs. Rachel, isn't it?
Yes, that's right. Good morning, Doctor.
Nice to meet you, Rachel. So, what brings you in today?
Well, it's about my little girl, Mia. She's 6 years old. Over the past couple of days, she's developed these spots all over her body, and I'm pretty sure it's chickenpox.
I see. Can you tell me a bit more about how it started?
Sure. It started with her feeling unwell. She was a bit more tired than usual and complained of a headache. Then, yesterday morning, I noticed a few red spots on her back. By the evening, they had spread to her chest and arms.
Okay. And have the spots changed since they appeared?
Yes, they have. Some of them have turned into little blisters now, and Mia keeps saying they're really itchy.
That does sound like chickenpox. Has she had a fever or any other symptoms?
Yes, she had a mild fever yesterday, about 38.5 degrees Celsius, but it went down after I gave her some paracetamol. She's also been a bit irritable, which I guess is because of the itching.
Understandable. It can be very uncomfortable. Has Mia been around anyone recently who had chickenpox or a similar rash?
Yes, actually. One of her classmates had it last week, and I suppose that's where she caught it.
That makes sense. Chickenpox is highly contagious, especially before the spots appear. Does Mia have any medical conditions, or is she on any regular medications?
No, she's generally healthy, and she's not on any medication.
That's good to hear. Is there any history of complications from chickenpox in your family?
No, not that I know of.
All right, let's talk about managing her symptoms. The most important thing is to keep her comfortable. You've already been giving her paracetamol for the fever, which is great. Avoid ibuprofen, as it's not recommended for chickenpox.
Oh, okay. I didn't know that.
Yes, ibuprofen can sometimes increase the risk of skin infections when taken during chickenpox. For the itching, you can use calamine lotion or an antihistamine syrup, which can help relieve discomfort. Make sure to keep her nails trimmed short to prevent scratching, as that can cause scarring or lead to an infection.
Got it. I'll pick up some calamine lotion after this.
Perfect. Also, make sure she stays hydrated and rests as much as possible. Chickenpox usually clears up on its own in about 7 to 10 days. However, there are some warning signs to watch out for.
Okay, like what?
If she develops a high fever that doesn't respond to paracetamol, if the blisters become red, swollen, or start oozing pus, or if she seems very lethargic or confused, bring her back to see me immediately. Those could be signs of complications, though they're rare.
All right. I'll keep an eye on her.
One last thing, since chickenpox is so contagious, make sure she stays home from school until all the spots have crusted over. This usually happens about a week after they first appear.
Of course. I've already informed her teacher.
Great. Is there anything else you'd like to ask?
Actually, yes. My son Ethan is 2 years old. He hasn't had chickenpox yet. Should I be worried about him catching it?
That's a good question. It's very likely he'll catch it if he hasn't had it before. Keep an eye out for symptoms in the next 2 weeks, as that's the typical incubation period. If he does catch it, it's usually mild in young children, but we'll monitor him closely.
Okay, I'll watch out for that.
Great. If you have any concerns or if Mia's symptoms worsen, don't hesitate to call or come in.
Extract 2. Questions 13 to 24. You hear a doctor talking to a patient called Mrs. Rima. For questions, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good afternoon, Mrs. Rima. I'm Dr. Kildare, filling in for Dr. Grimmett while he's away. How can I help you today?
Hi, Dr. Kildare. Thank you for seeing me. Dr. Grimmett asked me to follow up regarding some abdominal pain I've been having.
Of course. I've reviewed the notes, but could you tell me a bit more about your symptoms in your own words?
Well, it started a couple of months ago. I'd get this sharp pain in my upper right abdomen after eating, especially when I had something fatty, like fried foods.
Right, and how would you describe the pain?
It's really intense, like a stabbing pain. It usually lasts for about 30 minutes to an hour, then it gradually fades. Sometimes it feels like it spreads to my back or right shoulder.
I see. Have you noticed any other symptoms, like nausea, vomiting, or changes in your bowel movements?
Yes, I do feel nauseous when the pain hits, and a couple of times I've actually thrown up. My stools have been a bit pale sometimes, but nothing too dramatic.
And how often have you been experiencing these episodes?
At first, it was just occasional, but lately it's been happening more frequently, maybe once or twice a week.
That sounds quite uncomfortable. Did Dr. Grimmett mention the possibility of gallstones?
Yes, he did. I had an ultrasound a few weeks ago, and they found gallstones. He said we'd discuss next steps, but I haven't been able to come back until now.
Okay, thanks for updating me. The ultrasound confirms the diagnosis, so the pain and symptoms you're describing are likely due to gallstones blocking the bile flow. Have you noticed any yellowing of your skin or eyes?
No, nothing like that.
That's good to hear. It suggests there hasn't been any significant blockage or infection in the bile ducts. Do you recall if Dr. Grimmett mentioned any treatment options?
He mentioned something about surgery if it got worse.
Yes, that's correct. Gallstones are often managed based on symptoms. If they are mild, we can try dietary changes to avoid fatty foods and manage the triggers. However, for recurring or severe symptoms like yours, surgery to remove the gallbladder, called a cholecystectomy, is usually recommended.
Oh, I see. Is the surgery complicated?
It's a common procedure, typically done laparoscopically, meaning small incisions are used. Most people recover within a few weeks. Without the gallbladder, your body can still digest food, but you might need to avoid very fatty meals long term.
That doesn't sound too bad. Are there any risks with leaving it untreated?
Yes, untreated gallstones can sometimes lead to complications, like inflammation of the gallbladder, infections, or blockages in the bile ducts, which can cause jaundice or even pancreatitis.
That sounds serious.
It can be, but the good news is that we've caught it early. I'd suggest we arrange a referral to a surgeon to discuss your options. In the meantime, you can minimize symptoms by sticking to a low-fat diet and drinking plenty of water.
That makes sense. Do I need to do anything before seeing the surgeon?
I'll order some blood tests to check your liver function and rule out any ongoing issues. If your symptoms worsen, especially if you develop fever, chills, or yellowing of the skin, you should seek medical attention immediately.
Okay, I'll keep that in mind.
Great. I'll set up the referral and arrange for the blood tests. We'll follow up after you've seen the surgeon. Do you have any other questions for now?
No, I think that covers everything. Thank you, Doctor.
You're welcome, Mrs. Rima. Take care, and we'll be in touch soon.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear an instructor's objective on a refresher program. Now read the question.
Welcome to today's program. The objective is to provide a practical and comprehensive refresher for practicing optometrists, managing dry eye disease and related conditions. This course is particularly tailored to those focusing on primary eye care settings and aims to enhance understanding of the complexities of diagnosing and managing dry eye conditions. The program does not cater to those pursuing subspecialties or research in dry eye disease, as it is centered on common clinical practices. Sessions include workshops on innovative treatments such as intense pulsed light, IPL therapy, and lipid-based therapies, along with tools for patient education and compliance strategies. The program concludes with a roundtable discussion on challenges and opportunities in managing dry eye in routine practice.
Now look at question 26. You hear 2 colleagues talking about lab results. Now read the question.
Let's go through it. Elevated cardiac enzymes like troponins are key markers of myocardial damage. So, what's the normal reference range for troponins?
Oh, for most labs, it's less than 0.04 nanograms per milliliter.
Exactly. And what's the next step if the levels are elevated but not diagnostic of myocardial infarction?
You'd assess for trends by ordering repeat tests over time.
Correct. Now, do you see a pattern in these results that suggests myocardial infarction?
Well, the levels seem to be increasing significantly over time.
Now look at question 27. You hear a nurse educator and a nursing trainee discussing post-operative care for joint replacement patients. Now read the question. Now, let's talk about the key points in post-operative care for a patient who has undergone a total knee replacement. What would you consider essential in your patient education?
First, I need to make sure that the patient understands the importance of pain management. I'll explain how to take pain medication as prescribed and discuss non-pharmacological methods for pain relief. I'll also emphasize the significance of early mobilization to prevent complications such as blood clots.
Good. And what would you mention regarding the use of mobility aids?
I would explain how to properly use a walker or crutches and stress that they should avoid putting too much weight on the operated leg until cleared by the surgeon. Is there anything specific I should remind them about at this stage?
Yes. You should remind the patient that they may experience some swelling and warmth around the joint as part of the healing process. What's the final step in ensuring that they are well informed?
Before discharge, I'll make sure they know how to recognize signs of potential complications, like increased redness or fever, and instruct them to contact their healthcare provider if these occur.
Now look at question 28. You hear 2 hospital coordinators talking about a recent event aimed at recognizing and retaining volunteers. Now read the question.
So, what did you think about the volunteer appreciation luncheon?
Well, considering the number of volunteers who could make it, I'd say it was quite a decent turnout. It's always a challenge to coordinate an event around their schedules since many are already committed to their volunteering hours and personal lives. I was glad to see so many managed to come.
Yes, definitely. And the feedback form seemed pretty positive, which is a good sign. But from my perspective, I couldn't help but wonder if we put enough emphasis on recognizing individual contributions. Making sure each volunteer feels uniquely valued.
Yeah, that's a valid point. We could look into adding more personalized touches for the next event to make it more impactful.
I think we should.
Absolutely.
Now look at question 29. You hear two colleagues talking about a challenging patient. Now read the question.
Jamie, I have a patient case that's been quite challenging, and I could use your advice.
Of course. Happy to help. Are you referring to Alex, the young person you mentioned last week?
Yes, that's them. Alex identifies as non-binary and recently started therapy to address anxiety and depression. They shared that a lot of their distress stems from feeling pressured to conform to societal gender expectations. Their family is struggling to understand their identity, and Alex feels unsupported at home and in their social circles. On top of that, they've faced difficulties accessing gender-affirming healthcare, which only adds to their stress.
That sounds tough. It's clear Alex needs a support system that understands their experiences. I'd recommend referring them to a specialist who works with transgender and non-binary individuals. A counselor or support group experienced in gender identity issues could help Alex process these challenges. It might also be beneficial to connect their family with resources to better understand and support Alex's identity.
Now look at question 30. You hear a discussion on safeguarding patient privacy. Now read the question.
I'll be discussing an essential aspect of our profession, safeguarding patient privacy and ensuring compliance with confidentiality laws. In the past, we often discussed patient cases openly in shared areas like hallways or cafeterias, where information could inadvertently be overheard by unauthorized individuals. While this practice may have seemed convenient at the time, it has led to several breaches of confidentiality and complaints from patients, their families, and even regulatory authorities. Patients have a right to trust that their personal information is secure and used appropriately. A lack of trust erodes the therapeutic relationship, leading to dissatisfaction and reduced care quality. For these reasons, we are adopting a new protocol requiring all discussions about patient cases to occur only in designated private areas. This protocol also includes limiting access to patient records to authorized personnel and ensuring digital records are secured with updated encryption. By implementing these changes, we aim to rebuild patient trust and comply with the legal and ethical standards of our profession.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For question 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Extract 1. Questions 31 to 36. You hear Dr. Flora James, a physiotherapist specializing in musculoskeletal injuries, sharing a case study. You now have 90 seconds to read questions.
Hello, I'm Flora James, a physiotherapist specializing in musculoskeletal injuries, particularly in athletes. Today, I'd like to share a case study involving a long-distance runner in his early 30s who came to me with persistent pain in his left Achilles tendon. The pain had started as mild discomfort but gradually worsened over 6 months, particularly after long training runs or intense interval sessions. By the time he sought treatment, the pain was so severe that he could no longer complete even short runs without stopping. The patient was deeply frustrated because running was a central part of his life, and he had an important marathon approaching in just 4 months. He had tried rest, ice therapy, and calf stretches, but these had provided only temporary relief. Worse, when he resumed training, the pain returned almost immediately, accompanied by swelling around the tendon. He feared that his running days might be over. On initial examination, I confirmed classic signs of mid-portion Achilles tendinitis, localized tenderness about 2.6 centimeters above the heel, mild thickening of the tendon, and pain during passive dorsiflexion and active plantarflexion. However, there was no evidence of a tendon rupture or severe structural damage, which we verified with an ultrasound scan. His running biomechanics revealed some notable issues, including overpronation of the feet and inadequate calf muscle strength, which likely contributed to excessive strain on the tendon. The first step in treatment was to reduce the patient's pain and inflammation, while maintaining some level of physical activity to avoid deconditioning. I began by advising him to switch to non-weight-bearing exercises such as swimming or cycling at low resistance. At the same time, we introduced eccentric loading exercises for the calf. These involved controlled, slow-lowering movements with the affected leg, which research shows can stimulate tendon remodeling and strengthen the calf muscles. To address biomechanical factors, I collaborated with a podiatrist who recommended custom orthotic inserts to reduce overpronation. This helped improve alignment and reduce stress on the Achilles tendon during running. Additionally, I worked on improving the patient's flexibility through specific stretching exercises for the calves and hamstrings. These stretches were gentle and held for longer durations to avoid aggravating the tendon. After about 6 weeks, the patient reported a significant reduction in pain and swelling. At this stage, we introduced a gradual return to running program. He started with short, slow runs on flat, soft surfaces, alternating with walking intervals. Throughout this period, I emphasized the importance of listening to his body and stopping if any pain exceeded a mild discomfort level. We also introduced plyometric exercises, such as hopping and skipping, to help the tendon adapt to higher loads in preparation for running at full intensity. Another key aspect of the treatment involved educating the patient about proper running form and training load management. I explained how sudden increases in mileage or intensity could exacerbate the condition and encouraged him to follow the 10% rule, increasing training volume by no more than 10% per week. 3 months into the rehabilitation, the patient was running pain-free for up to an hour and had returned to interval training.
His confidence grew as he realized he could still achieve his goal of running the marathon, albeit with a slightly adjusted training plan. In the final stage, we focused on enhancing strength and resilience through higher intensity exercises, such as weighted calf raises and single leg squats, while continuing his eccentric loading routine. By the time of the marathon, the patient was fully recovered and able to complete the race without any significant discomfort. He continues to incorporate the strengthening and stretching exercises into his routine to prevent a recurrence of Achilles tendonitis and has remained injury-free ever since. So, before I go on to Extract 2, questions 37 to 42. You hear a detailed presentation on balance between effective pain management and avoiding dependency. Now, read the questions. You now have 90 seconds to read questions.
Hello, I'm Dr. Ethan Craig, a pain management specialist and researcher. Today, I'd like to discuss the balance between effective pain management and avoiding dependency in the context of the ongoing opioid crisis. Let me begin with a story. A 52-year-old woman suffered chronic back pain following a workplace injury. For years, she struggled with limited mobility and poor quality of life. Initial treatment included high doses of oxycodone, which provided temporary relief but resulted in dependency. She sought alternative therapies and began a multidisciplinary approach that included physical therapy, mindfulness-based stress reduction, and acupuncture. Within 6 months, she was off opioids, had significantly reduced pain, and regained mobility. Her story was later included in a national pain management research report. This case highlights a dilemma. While opioids can be highly effective for acute and severe pain, their overuse carries significant risks. Since the 1990s, when opioids were widely prescribed for chronic pain, we've seen the devastating consequences. Opioid-related overdoses and deaths surged, leading to what the CDC now labels an epidemic. Physicians must now navigate a dual responsibility, managing pain while minimizing the risk of dependency. Over the past decade, there has been increasing emphasis on alternative pain management strategies. Cognitive behavioral therapy (CBT) has shown promise by helping patients reframe their perception of pain. Non-opioid medications such as NSAIDs and antidepressants play a role in addressing both pain and its psychological impact. Additionally, interventions like physical therapy and yoga have demonstrated long-term benefits. However, these methods require time and effort, which some patients are unwilling or unable to invest in. Personalized medicine is another emerging field that could revolutionize pain treatment. Genetic testing allows doctors to predict how individuals metabolize medications, helping them choose the most effective and least risky options. However, challenges remain. Many patients demand quick fixes, and our healthcare system often prioritizes expediency over comprehensive care. While alternative approaches show promise, opioids remain a crucial tool in certain circumstances. Cancer patients, for instance, often require opioids to manage severe pain at end-of-life stages.
The key is to differentiate between appropriate and inappropriate prescribing. This requires robust clinical guidelines, provider education, and patient awareness. Let me share an example of innovative care models. A pain management clinic I collaborated with last year implemented a structured opioid reduction program. Patients were gradually tapered off opioids while engaging in complementary therapies. The results were remarkable. Over 80% of participants reported improved functionality and reduced pain perception after 6 months. But it's not just about clinical approaches. Socioeconomic factors also play a role. Many patients in underserved communities lack access to alternative therapies due to cost, location, or insurance barriers. This contributes to a cycle of over-reliance on opioids. It's critical to address these disparities to ensure equitable access to comprehensive pain care. One challenge is addressing stigma. Patients with chronic pain often feel judged for seeking relief, while those with opioid dependency face additional scrutiny. This stigma can prevent individuals from accessing the help they need. Whether it's alternative pain treatments or addiction recovery services, we must foster an environment of empathy and understanding in our healthcare system. In conclusion, while the opioid crisis has exposed significant flaws in pain management practices, it has also paved the way for innovative approaches. By integrating evidence-based alternatives, personalized medicine, and socioeconomically inclusive policies, we can achieve a better balance. Let's continue to prioritize both the science and humanity of pain care.
That is the end of Part C. You now have 2 minutes to check your answers.